Dr. Tim Keys, welcome to the Graduate Dentist Podcast.
Thank you, Erica.
It's an
Thanks for
absolute
having me.
pleasure to have you join us on the show, and in particular, as someone who's a specialist in a field that I think as grads we work quite a lot with, and that is obviously working with kids. I think the ongoing joke is that when you're a new grad at a practice, you get all the kids sent to you. Okay, and
Spot on.
yeah, I don't know about how other people felt, but for me personally during uni, we didn't get a lot of experience working with kids. And so it was kind of a learn on the job and learn how to navigate with it and like these tiny little patients that we have. And so I know myself and a lot of our audience probably have a lot of questions regarding like, how do we look after our pediatric patients. And so I really wanted to bring you on as an expert or someone who knows a thing or two, to kind of share your insight on it.
Yeah, thank you. And look, I will say I do feel very sorry for new grads because you're spot on. Whether you like kids or not, half the time you get lumped with kids, and it can be a really nice experience, or it could actually be a completely scarring experience, and you never want to see anyone under the age of 10 again for the rest of your life. The issue that I see as well is that in university, so I've trained grads and before for several years, your exposure to pediatric dentistry is really limited. Like, I think when I went through, I only had probably 2 or 3 students that actually extracted primary teeth. Um, and so mostly what you're doing is checkups on kids who are pretty compliant. Because I recall like an examination when you're in third year or your second year can take an hour. So you need a pretty compliant kid to tolerate an exam for an hour. So you get these really quite generally quite compliant kids that don't need a great deal of work on them. And then you go out to the real world, and particularly if you're in regional areas or poorer socioeconomic areas, and definitely publicly, you get kids who have very high needs, who maybe have had significant uh, bad experiences, and they're left with you. And you've got sometimes parents who are really difficult, very pushy, and there's financial constraints as well. So you add that all together, and it can be just a completely overwhelming and really stressful environment. So I 100% feel for your new grads, and hopefully out of today, there's just some easy tips and tricks that maybe we can cover that will make your new grads feel a bit more comfortable with this baptism of fire for children.
It 100% is, Tim. I think that's the best way you could describe it because it's so true. As new grads, you're navigating the world of dentistry. You're trying to figure out how to do things on adults, right? And that's hard enough as it is, let alone then doing it for a child who, have their all their like their emotions, and it's you're comparing a child and their ability to understand and tolerate things. It's a difficult enough as it is on an adult, isn't it? And I think there's also this huge responsibility that we play, particularly when we're working with adults who have, like, dental anxiety, and you ask where it comes from, and a lot of it stems from being a kid and not having the greatest dental experience. So now it's like, oh, not only is it hard to treat a kid, but you feel that responsibility pretty much for the rest of their life, right? It's like, I don't wanna, give them a bad experience that therefore sets them on the wrong foot and wrong trajectory where they then carry that anxiety all throughout their life. So there's a lot to it, hey? And I'm sure, you've got a lot of advice on it. The first thing I wanted to touch on, Tim, was you mentioned before about whether we like it or not. As grads, often you're the ones that get, or lumped all the kids. Do you think it's something that you either have a natural knack for getting along with kids? Some people say, "Oh, I love working with kids," or some people say, "I hate working with kids." Do you think that's something that's just black or white, either you like it or you hate it? Or do you think there's, like, way that you can sway or grow?
Absolutely. There's a fair like a lot of things in life, right? There's probably 20% either way, and then you got all the gray in the middle, the 60%, right? So you're gonna get 20% of people who are, for lack of a better word, probably hopeless dealing with kids, right?
Yeah. Yeah.
And it's not from a lack of trying, but it's just that their mannerisms and attitude are not ideal, or maybe they just don't like kids, and they're just like, look, I'd rather not deal with this cohort, and that is 100% fine. Right, and conversely, you're going to get a 20% of the population that just loves kids every bit as snot and smelly diapers and they're happy with the whole kit and caboodle, right? And then everybody else is going to sit somewhere within that in that gray area. And it's that gray area that we're trying to move up to liking children and maybe loving children as opposed to going the other way where they just don't want anything to do with kids because it's a really great skill to have in your armamentarium for dealing with kids. And the reason is if you can talk a kid off a cliff mid dental treatment, your skills and ability that you've learnt there are translatable to adults. And so what happens is if you're a lot more compassionate and patient at dealing with children, and you take that to dealing with adults, particularly those with some anxiety, and a fair portion of the population has anxiety with dentistry, even if they haven't had a bad experience, you're going to be a killer clinician because you're going to be able to provide care in a compassionate way, right? So that's where I think kids can teach us as clinicians how to manage all our patients really well. Now the question is how do you become somebody that's okay and likes kids, right? And you're right. Yeah, I mean, I was in the Air Force. There's not many kids in the Air Force as my immediate graduation experience. So I fell into that portion that just really liked dealing with kids, and that's where I knew I wanted to be. So don't ask me why I joined the Air Force. Um, but but for everybody else, where do you want to be? I think something that is really important to make clear is that if you really dislike kids, like you do fall in that probably 20%, make that clear to your employer early that I'm not comfortable dealing with kids. I really don't want to see my book 50% filled with kids, right? And so they might say to you, you know what, but that's what your job is, and then you might say, well, that's you know what, that's not for me because you can't. It's square peg round hole, right? It doesn't always work, and you'll hate it. So make sure you're really clear with them at the start what your expectations are. And in this current environment, graduates do have obviously negotiating power with where they want to be, right? Um, and then if you do kids, just be really careful who you pick to do treatment on and who you pick to not do treatment on, right? Um, everybody that deals with kids a lot has broken kids dentally, right? Like I had one just this week. It was a nearly 4-year old. I was doing a zirconia crown on their 5-1, and it was Johnny's Little House of Horrors, just screaming down the hallway for 20 minutes, but I'm halfway through it, so I've got to get it done. If that's your first experience, that's it, you're done, right? So I would really encourage everybody that if you're going to go with kids and you haven't had a great deal of experience, don't go and tackle a kid who's 4 with 12 holes all through their mouth. Like that is something that is not going to work very well. So pick your cases well initially, pick your kids well and pick kids that you like, and if you don't like them or you don't like the parents, you can make them my problem.
That's so true, Tim. Like when you say that, it brings me to a specific story. And I've probably shared it on our podcast before, but I would have maybe been in my second or third month out, hadn't had a great. I like kids, I get along with kids, but still working on them like clinically, I hadn't had a whole lot of experience. And this was a kid who had holes in all of his teeth, had been treatment planned 2 years beforehand at our practice. And you can see from his historical charting all these all these holes in his teeth, infected teeth, root stumps. He'd been treatment planned 2 years ago and hadn't gotten the work done. And so it comes back 2 years later. I asked dad, it's been 2 years since we've last seen him. Has he seen a dentist since? No, have not. Right. So you can only imagine that things are even worse. And so he had teeth that were just like huge infections. He was in so much pain and we needed to get one of his teeth out for him. I numbed him up. And then and he was a good kid. Like he wasn't a difficult kid, but he was just in so much pain, justifiably and understandably. And I remember he was so upset. And then I got really upset and I was really stressed. And I remember stepping out of the room and spoke to my principal dentist. And the first thing he did was, I still remember this so vividly. We went into Steri and he grabbed a new patient bib and he just put it on my forehead just to blot all the sweat off of my forehead. And he said this one thing where he's just like, you know, I think I said to him, like, I don't want to traumatize the kid. Like, I didn't feel comfortable continuing because I didn't want to traumatize the kid, and my principal said to me, "The kid is one thing, but you don't want to traumatize
Yeah,
yourself."
that's great advice.
And that really stuck with
Yeah.
me. Yeah. And I think what you said is just as with all skill sets in dentistry, you kind of have to pick your battles wisely. Start off with the good kids, the one that are easy, learn your clinical skill sets with them, and then slowly start pushing and knowing what you can manage and what's within your comfort range. There's a lot that comes with leaving university and properly adulting that no one really prepares you for. As a new grad with an income and newfound responsibilities we don't know what to do with, managing finances can be really tough. That's where JS Medical and Dental Finance comes in. Specializing in financing options tailored to medical and dental professionals, JSMDF is a completely independent broker dedicated to finding the best bank and lender for your unique situation. Led by the incredible Jason Savage, who personally came to my rescue and worked his magic and helped me secure a loan before I even started working, JSMDF is committed to supporting you throughout your personal and professional journey in whatever way you need. Whether you're looking to buy a house, a car, a practice, or pay off that year-long CPD course you signed yourself up for, JSMDF offer comprehensive advice tailored to your short and long-term plans. Their goal is to be with you from day one and thoroughly understand your financial needs and provide solutions that best work for you. And so if you're looking for some advice or you simply want to explore your options, get in touch with Jason and his team. A big thank you to JSMDF for helping make being an adult that extra bit easier and for supporting the graduate dentist community.
To be honest with you, the 85% of what I do is 5 or 6 things, right? So, we do surgical extractions and exposures and bonds and apexifications and that, but that's 10% of what I do, right? The vast majority of what I do is fillings, pulpotomies, extractions, crowns, and prevention treatment, sealants, fluoride, all the rest of it, right? So my skill set actually is generally quite constrained, right? So your skill set as a general dentist would be far greater than mine because you're doing, root canals on adult on multi-rooted molars, which I'm not doing. You're doing crowns. You might be doing bridges, full mouth rehabs. You're doing restorations. You're then dealing with kids, prevention, surgical extractions, whole kit and caboodle. So the actual provision of the dental treatment, as long as you're treatment planning it correctly, is not hard in pediatric dentistry. The hardest thing in pediatric dentistry is treatment planning. And what's the one thing that's not taught well in pediatric dentistry in universities? Treatment planning, because they spend all the time focusing on here's how you do a Fuji poo on a kid's tooth, right? And here's what we're going to do here. And so what ends up happening is you have a scenario exactly like you went through, and we see this all the time where a kid's got maybe 10 or 11 holes, they're a poor attender, and so they come into you, and maybe you're the third dentist that's seen them now. They've had 3 or 4 single visit extractions, right? And the kid's broken, right? But they've still got 8 more teeth to be treated, right? And it's not because you broke them or you did anything wrong. Like, Eric, in that scenario, the kid didn't like being numb. Yeah, that's kids, right? But I guess what I want everybody to do is actually take a step back, because how many true emergencies are there in pediatric dentistry? There's very few. There's a dental trauma. That's it. Everything else is not an emergency. Okay. Facial swelling, yeah, that's a big problem. Maybe that's an emergency, but you're not going to be able to provide treatment to a child with a facial swelling. Why? Because you can't get them numb. Even if they're a super compliant kid, very difficult to get them numb, right? So, therefore, what's a true dental emergency that you can manage and you should be expected to manage maybe as your first visit is a dental trauma. That's it. Everything else, broken tooth, kid not sleeping at night, sore tooth, intraoral abscess, I don't care. That is not an emergency, right? Why? Because that hole that's there, that's just appeared, that's been there for 6 months. That intraoral abscess that's draining, that someone's just noticed, that's been there for a couple of weeks, right? So if you just go and provide treatment on that one tooth, because that's what you got. You got a half an hour slot. Someone's just booked it in before lunch. The kids come in, they're bitten a minty, they've broken their tooth. The parent wants it fixed. You don't look everywhere else. You go fix that tooth. You're sweating by the end. You're blotting all the sweat from your head. The kid was not super compliant. You say, hey, you better come back. I've taken that one tooth out. You got to come back. I saw there's some other holes. And they come back and they are not compliant. Why? Because you did the hardest thing first. Right. And so you did in some regard there contribute to breaking them, whereby if maybe instead of that, we'd said to the parent, "Hey, I can see you've got a broken tooth here, but I can actually see there's a few other issues going on. I know your child's in a little bit of pain, and we're going to try and get that sorted as soon as we can. However, we also need to deal with the fact that you've brought your child here today. And it's very different when you're an adult and you take yourself because you know what you want and what you're willing to get. But for here, we need to determine what's best for the child. And my interest is providing the best quality work I can to your child without significant distress. And the best way to do that is to work out what actually the scale of the problem is. And then you do your full exam, you take your bite wings or your PAs or whatever you want, max occlusals, and you say, hey, actually, your 5-year old has got 12 teeth that are a problem. 4 are into the pulp, 2 are dead, and the other are just smaller variations of decay. If I just go and do an extraction as your child's first ever dental visit, what are they going to think a dentist does? Right? Pull
Just pull
out
a teeth.
teeth. And
Yeah.
what a horrible experience.
Mm.
Imagine being a 5-year old, and this is what happens, right? That every
Yeah.
time you go to the dentist, someone wants to do something to you. Right? Every time you go, they want to do something
Mm.
to you. They want to do something that you don't like. They want to put yucky tasting things in your mouth. They want to numb you up. They want to drill your teeth. They want to pull your teeth out, right? So we need to change that to be like, no, that's actually not what we want to do to you. We don't always want to do something to you. We want to come up with a treatment plan that involves the least number of appointments for the absolute shortest time frame and the least amount of distress to your child. And sometimes that's a general anesthetic. Not always, right? And I do know there's a perception that pediatric dentists put everybody to sleep. I promise you, we don't all do that. Probably 50% of my job is treating kids in the chair. Um, but but it's about trying to do that as efficiently as possible without breaking the kid. And ironically, if I've got a kid who's a bit borderline, I'm going to leave the hardest visit to the end. And even though the parent's principal concern is that one broken tooth, I'm going to fix that at the end. 2 reasons. One, if I break the kid, I break him at the end and there's nothing else to do, so I can build him back up. And 2, it means that the parent gets everything else fixed. Because I go take that tooth out, it's exactly like what you had before with the treatment planning sort of stuff. I mean, someone did treatment plan that. You take that tooth out, the parents lost the motivation to get their kid's teeth fixed, right? And it's not trying to be cruel, it's trying to work within the constraints of pediatric patients. So I would encourage every new grad to talk to their receptionist and their principal dentist and say the expectation in our clinic is that no patient gets treatment provided on the day. Every pediatric patient gets an examination as their first visit, irrespective of what the problem is. And then that means the receptionist has set the standard for what they expect. So the parent doesn't come into you disappointed that you've changed the plan and you're not actually going to go pull the tooth out. Now, you can still decide on the day if you think that that's appropriate, but the expectation is that the patient is getting an exam, x rays, and treatment planning.
That's a really great way of changing the perspective, Tim, when you're like, nothing really is a true emergency. And flipping that narrative of or that understanding that these kids are being brought here. They've not made the decision to bring themselves. So everyone else is making decisions for them. And yeah, what does that set the standard for their understanding and their perception of coming to a dentist? I have felt that with time over the years of like practicing, one thing that I've noticed is being less willing to be dictated by the parents in that I think when I first started, it's like, you'd have parents come in and be like, they've got a hole, like, I want you to fix this hole, or they've got a tooth that, you need this one thing done, and kind of taking a moment. I think maybe in my first year, I was almost pressured by patients or parents to do treatment. And then they'd always be put off by the idea of like seeing a specialist is so expensive, or like, oh, it's not covered by CDBS or whatever it is. Can't you just do it bit by bit? And I think in my first year, I would have said yes or tried it. And then you learn the heartache both to yourself and to the patients of trying to do it that way. And I think now I err more on the side of if you have a patient that comes in and they've got a mouthful of decay, I almost push the patients to saying like you're better off just seeing a specialist, maybe going under general, getting the work all done, and then starting again with us, almost starting afresh so that we can build that good experience with the dentist and just having checkups and cleans. It's a very different story doing a filling on a kid that you've seen for 6 monthly checkups than the first time they come to a dentist is to get a tooth pulled out and they've got all this other stuff and it just so many appointments and that distress just builds up. Hey.
What I would suggest to you as well, like if the parents are a bit resistant to do that as well, I would say, look, you don't have to necessarily proceed with treatment with the specialist, but maybe just go for a consult to talk to them about options. Because you nail it. Parents are the devil. Like the parents are so difficult, and they're getting increasingly more difficult. They want it free, they want it quick, they want it after school on a Saturday or on a Saturday when they think it's convenient, and they want their child to have a really fun time. And a lot of those things can't all work together, right? And so you need to be able to say no. And I see a lot of distressed new dentists in what I do with the training courses and things. I've seen APRA cases of newer dentists where things have gone pear-shaped. And I see kids that have gone through the newer dentists where perhaps, maybe they've seen a specialist and they've been treatment planned for a general anesthetic. They've gone back to their dentist. The parents have talked the dentist into doing something. They've provided work that's really quite limited in quality because that's all they could do. Things have blown up 3 months later, and guess who that parent blames? They they
The
blame the
dentist.
dentist, and it's a pretty scarring experience when you've got someone coming in and be like, "Well, you charged me for a filling, and the filling fell out. Now the tooth's dead. Now you got to pull the tooth out, and that lasted 3 months. You got to give me the money back." And you're like, "Well, but do you not remember that I told you you should see a specialist, but you wanted me to do it? And I told you that." And they don't give a shit. They don't care. So you have to say no, and I don't think that just applies to pediatric patients. That's everybody. If you get a perio patient that's got rampant, terribly controlled perio, don't feel and you don't feel comfortable doing the debridements. Don't feel pressured to do them just because it's cheaper, right? You're allowed to say no, and they can find some other poor sucker that'll do it and go pear shaped on.
I often say on the podcast that the more I do, the more I realize just how little I know, and how dentistry is just one of those careers where you never stop learning. But let's be real, getting the right training can be expensive, time consuming, and sometimes just straight up overwhelming. That's where Ripe Global comes in. Founded by Dr. Lincoln Harris, Ripe Global is completely changing the way that we learn. They offer immersive, hands-on training that actually fits into your life. Whether it's through improving your preps, getting faster with composites, or tackling more complex cases, you'll be learning from some of the best clinicians in the world without having to take time off work or spend thousands on travel. And so if you're serious about upskilling and boosting your confidence in the clinic, check out Ripe Global today. Hit the link in our show notes and let's start learning smarter, not harder. It's so true. Hey, Tim, you were mentioning how, a big part of your job really is the treatment planning. But I think on top of that, it's the behavior management, not just of your patient, but of the parent as well, because you see the ones that we send off to you guys. Hey, can you tell me about that from your perspective as a specialist? And also, I guess for people that are considering specializing, right? Yeah, I often hear this when people talk about ped specialists, whether it be in dentistry or in medicine, whatever it may be, and like, oh, because I really like kids. And you guys, but you're the one that actually sees the kids that don't like you back, right? Or you see the ones that are difficult. What are things that you've learned in terms of navigating these difficult scenarios with distressed patients and difficult demanding parents? What is the best piece of advice you have in terms of having those conversations, setting expectations, setting boundaries so that you can do the best work you can?
Erica, I'm very boring, right? I do exactly the same thing every consult, every examination. Like my dental assistants, they wouldn't even need me in the room. Oh, you could put me on a recorder. It's exactly the same process. Now, I still want every kid and parent not to feel like this is the thousandth time I've done this, right? But I'm a recipe. I am a cake, right? Vary from the cake and I'm in strife, right? Vary from the recipe, I get a bad cake. So I need to stick to the same thing. And why? It's because it's systematic. So therefore, I'm not stressed about having a really disruptive kid or having a really awesome kid. Now, the really awesome kid's a lot more pleasant for me to deal with, and I can have a lot more fun with them, but they get exactly the same steps that the really distressed patient gets. Why? Because you can turn every really good kid to a bad kid. I shouldn't say bad. You can turn every really compliant child to a non-compliant child if you skip steps, right? So, and it all comes down to that expectation. So, like I said, your reception team's actually brilliant because they're the ones who are going to set that standard initially for what the kid's going to get, right? It's going to be an exam. And so, therefore, few little tips that I think can help uh, the practitioner, so whether it's a therapist, dentist, whatever, they need to be the person that gets the kid into the room, not your nurse. Why? Because that means your first interaction with the child is in hopefully a less threatening environment than a room. So you're a general dentist, right? You might see 6 kids a day, and then you'll see 5 adults a day, or vice versa, right? If you've got a nice, colourful room with some pictures on the walls that kids have done a colouring in, do you think the adult would be upset about that? No. If anything, they might think, oh, this dentist looks like they're a nice person, right? Now, the benefit of that is too, where does the kid look if you have nothing on the walls? They look at the chair, right? And what does the chair look, friendly or unfriendly? Super unfriendly, super unfriendly. So when you walk into your room, what you should have is something visible immediately, is something colourful and bright that draws the eyes away of the child from the chair. Why? Because the last thing that you're going to do is put that kid in the chair, right? Because if you go and tell the little 3-year-old to go jump in this big, scary looking chair that's built for an adult, they don't want to get in that because they're in a vulnerable position. They have to lie down. So you want them to go do something else. So you want them to have their eyes drawn to some pictures on the walls or whatever you've got, right? Or you get some little, you can have a little big teddy bear. I don't care what you got, but usually pictures are nice and easy.
I have a dolphin on my room.
Fantastic.
It's Stanley the dolphin.
Fantastic. You've got something, right? And then get
Mhm,
the kid to do
mhm.
something else. Get them to color in, whatever. And then you're going to spend that first 5 minutes talking to the parent, right? And you say to them, hey, what are you here for today? They might say, look, my first checkup, whatever. My kid's got broken teeth. They haven't slept, whatever. You run through the medical, and you also say to the parent at that point, this is what we're going to do today. What we're going to do is we're going to have a look, and we're probably going to try and get some x-rays, right? I'm unfamiliar to your child, so they might get a bit upset. If they get upset and you're getting a bit worried or you're seeing them get upset, you can stop me and I'll stop. But just be aware sometimes I might get a limited look if you stop me too early. And that's on them, right? And then you get the kid, and you need to try to somehow broach with them, particularly those really anxious kids, about what's going on. So, for example, I'll just get a two colored toothbrushes, whether it's green and red, and I'll give them the choice. What do they want? Every kid only gets 2 choices, Erica. That's it. Ever in life,
Mhm,
2
mhm,
choices. Do never give a kid
mhm.
a toy box and let him pick. You'll be there for 2 hours, okay? 2 choices,
So true.
okay?
I've been stuck there
Yes,
before.
okay,
Mhm,
and then they
mhm.
can have the toothbrush, they can have a go, and you say, "Look, I'm just gonna count your teeth. Can I see if you've been brushing your teeth?" And you get the mirror, you can pretend to look behind their ear, you can do little magic tricks, whatever you really like, right? And then you'd make sure that they have control. Let them push the buttons to recline the chair. Right? Why? Because they've got a modicum of control. Okay. And then obviously have your look. Make sure you show them everything before you do it. Blow the wind on their hand first before they use it. If they look like they're anxious, let them pick the tooth that you'll dry first, right? And just have that continuing on. Once you're finished, every kid gets a prize. If you practice and your practice owner is too much of a cheap ass to buy prizes, just get some stickers, buy himself dollar, whatever. Buy a bag of things from Timu for $1 each, whatever. It'll make your life a lot better because then the kids can get a reward. Every kid needs a reward. Find something to reward them on. Okay. And then finally, now you've got all your info, you got your x-rays, you had your exam, you then re-distract the kid, whether it's with an iPad coloring or your DA can do it. And now you spend 5 or 10 minutes, depending on the complexity, talking to the parent about what issues they have, what options they have, and how you're going to do that. Okay. And that way, you've actually sounded out the parent and let them talk a bit, right? And if you get someone who looks a bit dubious and they're looking a bit doubting, just ask them, look, what do you want? Like, what's your aim out of this appointment today? And make sure that way you can keep them satisfied as well.
Mm. One question I wanted to ask you, and I know that I've made this mistake in the past as well, is that conversation with the parent and the conversation with the kid. Because I think sometimes, particularly if the kid's just sitting in the chair, we almost forget that they're there and that they can hear and they can listen and they're listening into the conversation. And I've made the mistake before of just focusing on talking to the parent and, little Johnny, whoever is sitting there, and they're getting anxious because they don't know what you're talking about and you're talking over them and you're kind of forgetting that, hey, they're there and we're talking about them. And so it was interesting, I guess, when you talk about distracting them, or would you ever have them away from, like, out of earshot of the conversation, or are these conversations whilst they're present? Like,
Commonly, we're in our rooms. We've got quite big rooms, right? So we've got little colouring in tables in the rooms and things. But I appreciate other people don't have that. We've also got iPads for each room with headphones. So once I've finished my exam or whatever, the kid gets the iPad and the headphones, or they get taken to the toy machine, or they might go back to the little cubby house we got out the front. So that way I can talk to the parent without the child listening, because I need to be quite blunt with the parent sometimes and realistic about, like, hey, your 5-year-old has 4 quadrants of dentistry to do. 45 minutes each one with numbing, drilling, extractions, nerve treatments, XYZ. And I don't need the kid hearing that, right? The other benefit of that is that I can then, if the parent says, yeah, look, you know what, I'm up for it, my kid's up for it, let's get going. I can also then be very clear to the parent what I want them to tell the child. And so there's quite some distinctive language that I dislike parents saying, right? And anyone that's treated a few kids, they definitely would have had a parent be like, oh, it just hurts a bit. It's just a small sting. They're just going to rip your tooth out. Be really brave. I hate brave. Why, Erica? What's brave meant to be? Tough.
tough.
You got to go overcome something you're scared of, right? To be brave. You're scared of heights, so you need to be brave. So why does any child need to be brave in the dentist? What's it implying?
That it's going to be
Spot
scary.
on.
It's going to be, yeah,
I hate brave. Because if the parent says, I just need you to be brave, it means because the kid needs to be scared.
I need to be scared of something.
Correct. So you
Yeah.
know what's a much better
Mm.
word? Let's try. Let's try
Mm.
something. Okay. So rather than let's just be brave for this, is hey, let's give this a go. Let's try. Let's see what happens. Is there any problem with failing and trying? No, that's okay. We fail at lots of things in life. So, but we had a go. That's okay. Then we can still find something to reward, right? You tried. You had a go at it. Well done. So these are the words I'm talking to the parents about. I pretty much tell them to shut up. I just want them sitting in the corner. I'd much rather they sit on their iPhone, or actually, I'd love it if they weren't in the room, but legally, it's much better to have them in the room. But I want the parent to be a completely passive individual over there, because half of them are really intense people and they make it so much worse. There's nothing worse, for example, when you're about to give local anesthetic to a kid and then the parent comes over and
And
grabs the
starts.
leg, right? And what does the kid think? Oh shit, something's happening.
I gotta
Yeah,
be
yeah, yeah.
scared of something.
So I'm
Yeah.
very clear with the parents, just saying, hey, look, I know you probably want to prepare your child really well. And I've had heaps of parents, sadly over time, who are like, oh, I've already just told them they're going to get a needle. And I'm like, no, mate, we don't talk about needles here, right? We don't talk about pulling teeth out. We help teeth fall out, right? So it's just changing language they talk. But I usually say to most parents, this is what we're going to do. We're going to start with something easy. And why do we start with something easy? Because, for example, if they can't get through a clean and some sealants and some silver fluoride, they ain't going to sit it for an extraction. If they can't get x-rays, you legally should not be giving them a filling, and they can't tolerate a filling, right? So you start with something easy, and then you're in charge of what the message is. So just tell the parent, hey, look, we've got some really complex work to do here, but we're going to start with something easy, and you will see how I'll do that. But I know you probably want to prepare your child, but you'll see that we'll prepare them on the day. So just say, hey, we're coming back to see Tim. We're going to go to the toy machine once we're done. He's going to tell us everything that's going to happen, right? And that's all I want the parent to say. Nothing else, right?
Mhm. Don't
No,
give any
and we'll tell the
information.
kids.
Don't try to
Spot on.
over-explain.
And then what I will do at the end of the consult, parent says, yeah, cool, next visit's going to be, even to say, next visit's going to be an extraction. I will talk to the child in completely different language than the parent. And sometimes I'm talking to the parent through the child. So I'll say to them, hey, look, next time I see you, we're going to, that tooth that's a bit sore, we're going to help to fix that tooth. Okay. But you know who the boss is when they come here. And the parent and the kid will always say you. You say, no, it's not me. And they'll say it's mum. You say, no, it's not mum. They never say it's a dad. I promise you that much. All right. And then you say, no,
Yeah.
it's actually you. You're the boss. So if anything ever doesn't feel right, or you're worried, or you just want to talk to me, you're going to tell me. And what am I going to do? And they're going to say, you're going to stop. You're spot on. So at no point in time do you ever need to worry that I'm not going to stop. The second thing is when I help your tooth fall out or I do X, Y, or Z to you, is it going to be easy or is it going to be hard? And the kid will say hard. And you'll say, no, of course it's not going to be hard. It's going to be easy. Can I tell you why? Why? Because I'm lazy. I only do easy stuff, right? I leave all the hard stuff for other people. So the fact I'm seeing you, remember, you're the boss, you're in charge. I will tell you everything before I do it, okay? And it's not going to be hard because I'm too lazy to do hard stuff, okay? And that's it. Conversation's done. They know that they've got something coming, so that we're not like going to spring something on it. The other thing sometimes I'll say to them is, I promise you something. I'm not going to lie to you. And the reason I'm not going to lie to you is if I lie to you, are you going to trust me more or less? The kid's going to say less. And you say, right. And is that good for us or bad for us if you don't trust me? It's really bad. Okay, so I promise you I'll never lie. And now we never lie. You never tell kids this isn't going to hurt and you start doing a filling and you haven't got local link because it will hurt and then you've lost trust. Once you lost trust, there's an F word. We won't use that one, but you're
Mm.
stuffed. Okay. So you don't lie.
Yeah.
You can rephrase things, right? But you don't lie. You don't need to talk about a needle. You just rephrase it.
Mm.
Okay.
What do you say then to will it hurt?
It doesn't hurt, Erica. Yeah, it doesn't. You make sure it doesn't hurt. So the one thing that's massively underdone in pediatric dentistry is the provision of local anesthetic. Right. So many people are so much scaredier. Is that a word? Scareder. They're more scared of giving a needle than they are of the procedure. So they sit there and think, look, this hole doesn't look that big. So I'll just drill it and it'll only be sore for a few seconds. So but I'll tell the kid it won't hurt. They just feel a little tickle on their tooth. It does hurt. It really hurts. Kids have larger neurovascular bundles than adults do. Now, we don't go and do a filling on an adult without local. So if you think something's going to hurt, you need to provide local. And local is actually the easiest part of my entire procedure, right? So, and it's just doing it very methodical. It's also the longest part. To take a primary tooth out should take you no longer than 60 seconds. If you're there for longer than 60 seconds, you're doing something wrong, right? But I need 30 minutes to do that. Why? Because it takes me about 10 minutes to get the local in through all your steps and the language. So, Erica, nothing does hurt and nothing should hurt, right? But you're also very clear to the parents. For example, if you're doing an extraction, in that discussion you have with them, I'm very clear. And I also say it to them on the day. So, on the day they come in for the extraction or the procedure, whatever it is, I say, hey, to the kid, come on up, let's go have it. Hey, do you want to grab a seat in the chair? Pick what you want to watch on the TV on the roof. I'm just going to talk to mum for a sec, right? Then I go out of the room and say, hey, we've got to numb them up today. We've got to take 2 teeth out, all right? Your child will leave here upset, even though I know they're happy here today. They're going to leave here upset. They're going to say that their lips sore. They're going to say it's swollen. They're going to say it's stinging or it's hurting. It's not, it's numb. Kids hate being numb. So if they're upset and crying when they leave here, it's not from pain. It's because it's numb. It'll wear off in about 2 hours. There's nothing we can give that can make it wear off quicker. The second thing I'm going to tell you is your child is highly likely to think that the pressure when I'm helping the tooth fall out is pain. It's not pain, it's pressure. I'm going to demonstrate to you that they are very numb before I start taking the tooth out. If I've got that tooth flapping in the breeze and they start getting upset, we're just going to have to hold on and just finish it because it's already half out. There's nothing worse, Erica, than you half extracting it and then sending for me to do 2 days later because it ain't going to go any better, right? So just hold on and get the thing out, right? But you've discussed that prior. And then once I've got the kid numb, I'm going to get a sickle probe and I'm going to say to the child, hey, I'm just going to test to see if your tooth's sleeping, okay? Can you let me know if you feel anything? And I say to the parent, hey, mum, come over here, have a look. See this? Have a look. And I get it and I jam it up the buccal and I jam it up the palatal. And I say to the kid, did you feel anything? Nah. Say the parent, see, it's numb. Okay? So if they complain now, what is it? It's pressure. Spot on. Okay? And you got to luxate. You got to luxate primary teeth. So many people fracture roots of primary teeth and they just leave them in there. Luxate, you got to luxate. Anyway, that's a completely separate topic.
You all know that if there's one thing I am super passionate about and always advocate for on our podcast, it is our mental well-being as dentists. There's no denying that our profession can demand so much from us, and it can drain us physically, emotionally, socially, and mentally. And some days it can all just feel a little too much. This is where our friends at Dental Practitioner Support come in. Whether you're new to dentistry or have been practicing for years, Dental Practitioner Support is here to offer guidance, reassurance, and a safe space to talk about whatever it may be that's weighing heavy on your heart. They provide 24-hour services that are completely confidential and independent, so you know that you will always have someone to turn to. Whatever your scenario may be, Dental Practitioner Support is just one call away. And so, in case you ever need it, save the number 1-800-377-700 or visit their website at dpsupport.org.au. Remember, as we say time and time again on the podcast, you are never alone, and we really are all in it together. Building on that point there, where we talk about, I think one of the biggest stresses and anxieties for new grads is not wanting to hurt the patient. And I think that's just, yeah, the whole part of not wanting to upset them, not wanting to hurt them, perhaps as you say, not giving LA as well as they could, not giving enough, or not giving it in a way that the LA administration is painless, right? Um, in that process, the kid does get upset. I mean, sometimes it may be inevitable that they get upset. As you said, they may be numb, but they don't like the feeling of being numb, or they don't like the pressure, or whatever it may be, and they get upset, right? How do you talk them off the cliff? And how do you do that and, manage mum or dad being distressed as well? What's your best advice for navigating that?
Erica, if you discuss something before a procedure and it goes wrong, what is it? It's a risk. If you discuss something after you began the procedure and something went wrong, what is it? It's an excuse or it's an F up, right? So that's where it all comes down to talking to the parents prior. You gotta be really clear. If you've got a kid who you think's a bit borderline on getting a procedure done, you need to make it very clear to the parent that you've got an escape cord you're going to pull on when you decide that you've had enough. And the kid has one too, and the parent has one as well. Okay. So at some point, you're going to hit that, and we all hit it. And I hit it commonly, right? Where I'm like, either I pull the cord or the kid pulls the cord or the parent pulls the cord. And we're like, we've had enough. And it's very clear at that point in time, it's all over. In saying that, the only exceptions would be really if I'm mid pulpotomy or if I'm mid extraction and then I've got to finish it. So I sort of say, look, let's hold on here. But you don't want to be discussing that when it's mid meltdown, right? So that's where you need to talk to the parent prior and say, hey, I don't know how your kid's going to go with the extraction. They're really struggling with sealants, and I really struggled with X-rays. So, maybe we need some extra firepower, some nitrous, or maybe you need a G8. Okay, you want to do that? Cool, happy days. So I just need to let you know if if we can't get it numb, and they won't let us get it numb, well, that's the end of the story, right? Or if they get really upset before I really start, well, that's probably the end of the story as well. And just so you know, I need to go home and sleep and feel well. And if I have a really bad experience on your child today, it's going to affect me as well. So I want to make sure that I can do the best job I can for your child. And so if they get upset, we might stop. Now, let's say midway through a procedure, doing a filling or something, and the kid starts getting really upset about something, you've only really got one opportunity to talk them down, right? And there, I commonly see patients who come in who've had a 1 hour extraction. They've been numbed up 3 times. So they've had like three, two and a half cartridges a local put in, and they've had their extraction process went for an hour, and the tooth's still not out, right? Children are terrorists. You cannot negotiate with terrorists. Okay. So we need to be really clear. You got one shot, right? If you've lost that kid, you've probably got one chance to get them back down. After that, and after a couple of minutes, you got about 2 to 3 minutes. After that, just up stumps and you're done. Okay. Don't keep pushing it. So if they start getting really upset, I usually provide all treatment, local anesthetic, anything like that under nitrous, Why? Because it just gives you much better compliance, and it's much more pleasant for the kids. And so, what you generally want to do if they start getting upset, they're going to start breathing through the mouth, which means they're not getting happy gas in. Even if they don't have happy gas, you need to get their heart rate down. You need to get their sympathetic nervous system to relax. So, you need to do really big, deep, slow tummy breaths and just pause what you're doing in big, deep, slow tummy breaths and just make sure that they know that they're in control. And just then talk to them and say, hey, what went on? What happened? I could see you got really upset. You got really worried. Did something change? They'll be like, oh, look, I tasted this really yucky thing. You're like, okay, cool. No worries. Well, we can fix that. Or I didn't like this feeling. Okay, well, let's see if I can fix that. Or if you can't fix it, because it's the pressure of extractions or something, you need to explain to them. But you will have already told them that prior. So if your kid sits up and says, I just need a cuddle from mummy, I just need a cuddle from mummy, just quick cuddle. Once they're latched on, they don't want to come back down. So don't spend an hour negotiating. Just say, hey, look, we tried, we did our best we could. Hopefully you've come across in a really compassionate way so the parent doesn't think you just rushed it and you had a crack at it and that's what upset them. So it's you took your time, you were compassionate, and you're like, look, I'm really sorry, we can't do this. As we discussed at the initial visit, there's a chance that you might need to go see a specialist. And I think we're at that point now where I can't provide treatment to your child. So can I put you in contact with one of my friends who's a pediatric dentist who's going to take really good care of your child? And hopefully you got a nice friendly pediatric dentist around the corner.
Suspicious.
Yeah.
I do like that there, how you kind of need to have your, um, yeah, like you said, that recipe of what do you do so that you have that same recipe each time you tackle it. You don't start pulling out new techniques and scrambling for grasping at straws trying to make things work. As you said, I find it perhaps challenging sometimes with like, oh, mom and dad wanting to step in and console them and cuddle them, or talk them through it all. But I think, as you said, keeping in control of it, and knowing when to call it. Does it change the older the kids become? Because we've talked about it, and this may be, I guess, applicable for someone quite young, a 4 or 5-year-old. But once they get to, say, like 11 or 12, and they're quite understanding, they're clever, they know what's going on. How does it change when you work with older kids, or does it
Not
not?
really, right? But you just might involve them more in the discussion, right? Do they still need to know they got a needle? Probably not. No. Do they feel it? Hopefully not, if you give a good technique, right? So you don't want them feeling it. So they don't need to necessarily know about it. If they ask and they're 13, they say, hey, are you going to give me a needle? You can't lie, right? So you say, hey, look, to put your tooth to sleep, we do need to do that. But I'm going to make a bet with you. If you feel it, you can give me one. Sound fair?
Mm.
Yeah,
Have you
cool.
had to been given one yet? No.
No, not yet. Not yet. But one thing I will say, most dental people are excellent, generally speaking, at giving needles, and we're far, far, far better than our medical colleagues. Our medical colleagues are absolutely shithouse at giving needles. Why? Because we have to give it in such a vulnerable part of the mouth. Um, don't rush it. Okay, make sure you take your time. Make sure you got topical on and use distraction. Whether you're like when I go give blood, what do? I wiggle my toes. Why? No one likes a needle, right? So if you can give a needle well to kids, do the same process for adults. Never, ever on anybody give a palatal injection as a first point of call. Did you get a palatal injection, Erica, when you went through training?
I've never. No, we didn't even give each other blocks.
Oh, that is disgusting.
I've never had a block.
Oh my
I am
goodness.
I have said that I need to find a good friend and, to experience it myself, because I've not actually received one.
You need to get a block and you need to get a palatal injection given without topical as your first point of call. And then I guarantee you, if I'm not saying you're not, you're probably a very compassionate human being, but you're not going to give an adult or a kid a palatal injection. What are you going to do? It's the same process for kids or adults. You numb up the buckle and you're going to go all the way through and you're going to take your time. Numbing takes about 5 minutes, takes a long time. But if you can give needles well to adults, they're going to love you. And they're not going to care you did a turd burger on their tooth of a filling. So as long as you give a needle well, they're happy.
Tim, you mentioned before about like the changing landscape, and I wanted to ask you, as someone's been practicing for a while, what have you noticed in differences in terms of the patients, like I guess these young patients that you treat, whether it be like dentally differences that have changed over time, or behavior, or parenting? Have you noticed a change since you began practicing?
Absolutely. Big game changer for us was the introduction of a hall crown and silver diamine fluoride. So, for those not aware, a hall crown is a stainless steel crown put on a tooth with no numbing and no drilling, right? It's got strict criteria of when it's an appropriate treatment plan, and we can't go through that today. But that's been a big game changer. Saved a lot of general anesthetics. And the other one's silver fluoride, which for some reason is kept for the newly born and the newly dead, but it should be used on everybody. And for example, I've got it used on one of mine. I've got a distal, probably borderline carious lesion on my 2.6 that I guarantee you 99% of dentists trying to fill it will hit my 7, and I'll end up with a filling in my 7 eventually because it's not in a very good position. And I've just been maintaining it with silver fluoride for a long time. So that underutilized massively silver fluoride is, but those two things dentally are pretty significant for peds dentistry. Zirconia crowns, we do a lot of zirconia crowns now, so white crowns for teeth. So and that's been a big change as well, because you can imagine back in the day we had a reasonable portion of parents that their kids needed zirconia, a stainless steel crown. They really didn't want it. And so we didn't really give them some choices sometimes because they're like, I'm not going to do a filling on it because it's going to fail. Um, but that's been a big game changer for us. It's significantly improved the success rate of primary anterior fillings, anterior restorations, and posteriorly. For patients themselves and parents, they're getting increasingly much harder to deal with. Increasingly much harder. Patients themselves are okay. I mean, there's more diagnosed neurodiversity. I don't think necessarily there's more kids with neurodiversity. We're just aware of it more, right? So I don't think that's a big problem. And to be honest with you, the kids are not the problem. It's the parents. We're getting a significant increase in difficult parents. Like I had one of my receptionists resign earlier this year just because she got sick of getting abused by parents on the phone. She said, "Look, I want to go back to general dentistry where I don't get abused by parents." And you wouldn't think a parent would call up a private pediatric dental practice and just tear the ass off receptionists for no reason, just trying to do their job. But they do, and they're quite difficult. The one piece of advice I would give you, and all my staff know this at my practice as well, we've got your back. You don't need to put up with a difficult parent. If someone doesn't treat your staff with respect, you need to not provide care to them. There's nothing worse than a parent coming in or even a patient, and they come in and they tear the ass out of the receptionist or they're really mean and rude. And then they come in with you and they're nice as pie to you. But that is not a good person to have in your business or sorry, in your practice, right? So you need to stand up a bit for your receptionists. They're going to love you for that, right? And they're great advocates for you because they control the appointment book too. And if you're a new grad and you get on really well with your receptionist,
Mhm.
where the patient's going to go, right? So they need to know that you've got their back
Yeah.
like they've got yours, right? And if you do get a difficult parent, you're very well, once again, you just pull that escape cord and you say, hey, look, I think what your expectations are and what I can provide don't really quite align. Your philosophy on your child's treatment isn't something that I can provide. And I just want you to know that we both really do want the same outcome. We want the best result we can get for your child, but we both have different journeys in our mind about how we're going to get there. So, can maybe I find you someone that can provide that care to your child in a way in which that you might agree with more than what I can do? Okay, and that way you're not just telling him to to disappear. You're trying to compassionately talk to them, and it is true. You both want the best outcome for the child. It's just that they're a completely cooked anti-fluoridator that doesn't want composite resins or Fuji, and they want to do oil pulling, and the kid's got 6 abscesses, and that's fine. You just need to get rid of them. Yeah.
Yeah.
And then that's when you find your unfriendly pediatric dentist and you send them to them.
I was sent to
Yeah,
this.
yeah, 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 absolutely.
Your good friend down the road there. No, that's really awesome. Tim, I wanted to wrap it up soon, but I wanted to kind of run through a few quick fire personal clinical questions. I don't want it to become a full lecture, and I know you have so much content out there on your blog posts and all this information for dentists to access to. Um, learn more about this. Some questions that come up quite often with our community, though, with regarding treatment for patients. And so just want to do a quick fire speed round to get your input on things. But we obviously mentioned the first one, which is stainless steel crowns. Do you prep or do you not prep?
It depends. If you have no pulpal involvement, you can do a Hall crown. The criteria for that is you need to have a clear radiographic band between the level of the cavity and the pulp. If you've got that and it's restorable, you can put a Hall crown on. By restorable, I mean sometimes the decay may not be to the pulp, but the margin is so deep. Or, for example, on a D, the E has like tipped in to the D a bit. So you physically can't sort of get the crown on to go around that. And that's where you might need to prep, even though you don't need a pulpotomy. But the vast majority of cases, if the decay is not in the pulp and you keep the crown on nicely, you don't need to prep.
Mm. When do you decide what are clear signs for whether you do a pulpectomy or if you should extract the tooth?
I don't do
Oh, sorry, a
pulpectomies.
pulpotomy or extract the tooth.
Pulpotomy.
Yeah.
Okay. So pulpotomy is when you radiographically the carious lesions into the pulp.
Mhm.
Okay. Most primary teeth will have a abscess that'll appear in the furcation region of posterior molars because that's where it's very thin, the tooth. So you need a PA, right, before you do it. So you want to be see A, that it's restorable, so you still got some tooth to deal with. B, the tooth is vital, so you're looking for no significant nocturnal pain. Okay, no abscess, obviously clinically, and radiographically, you're not seeing any large radiolucencies or significant root resorption, and then you're okay for pulpotomy. Once again, always discuss with the parent prior. If I drill into this thing and this thing's dead, we're going to take it out.
What's your favorite material to do fissure seals?
If you use a resin based sealant at 5 years, if done properly, 80% of them will be there. If you use a Fuji to do a fissure sealant, it's like a Fuji 7 or Fuji 9, at 5 years, 5.1% of them will be there. Okay. So I'll use a resin based sealant generally. You'll etch for 30 seconds. You'll put bond on and air dry it. Don't cure it. And then I'll use a 3M based product called Climpro.
Then for restorations, I know you probably well, actually, I guess would you still do restorations perhaps in your work? I don't know if you still do for things. Preferred material of choice? GIC or composite?
Only place for GIC and paediatric dentistry is under a crown. Okay. Why? Because it's temporary fillings for temporary teeth, right? But you're putting Fuji on a 4-year-old, that needs to last 8 years. That ain't going to last. So we're going to use composite or compomer. Most people don't use compomer. It's the opposite end. You know, on the scale, you got Fuji, and on the other end, you got composite. Then you got RMGIC, and you got compomer. Okay. But composite mostly used under. What are we
Rubber
going to make sure?
dam.
Rubber dam, spot on. Massively underutilized for kids. What's the number one thing that kids hate? Taste. What does everything in dentistry taste like? Tastes like cat's wee. All
Mm.
right. So we're going to use rubber dam. We use rubber dam on everybody. Okay. But yeah, definitely. I'm quite reluctant to restore D's with intracoronal restorative materials. Not saying you can't, but the reason is even done with composite, the failure rate sits at about 40% at 3 years.
Specifically for these?
Yeah, you got very little enamel to bond to. I'm much more confident doing a composite restoration or something like that on a knee. But anytime you move to multi-surface, so let's say you're doing an MO and it gets a bit big and gets pretty wide, and you start thinking, "Oh shit, I'm going out the buccal and palatal here." Your failure rate goes up by magnitudes in primary teeth, right? The reason is the enamel there is less mineralized and there's less of it. So you got bonding that's greatly inferior to a permanent tooth. But I still do a heap of restorations, but I pretty much refuse to restore Ds now with composites. Not saying
Which
you
is
don't have
fair.
to do that, but you just got to accept a pretty high failure rate.
No, thinking back now that I didn't actually realize that, but as you mentioned that, I'm like, oh, yeah, when I think of my peds patients and if they've got failing restorations, it's usually on the D.
It's always the
And
Ds.
it's always
Yep.
the D. Yeah.
Yep.
Last speedfire question. You mentioned painless LA, doing it well. What's your favorite LA distraction? Tool or story or
Yep. Um, it depends. It's horses for courses, right? But my general one that I'll do is obviously you'll ensure that topical anesthetics on for at least 3 to 5 minutes on desiccated mucosa. Then you'll take that off, give them a good rinse, and then I'll say to the kid, They've got TV on the roof. And so they usually for me got nitrous on as well. Say to them, hey, I'm going to put your tooth to sleep now. When we do that, I'm going to get you to do three things. More so for kids that are not too distracted by the TV. So if they're sort of looking around a bit and getting a bit antsy, I'll say, what I want you to do is close your eyes and I want you to do big, slow breaths through your nose. And I'm going to get you to wiggle your toes. Okay. You're going to feel my finger just up on your gum. Sometimes it can feel a little bit cold. If it feels a bit cold or it's a little bit uncomfortable where my finger is, you just put your hand up and we'll stop and give you a break. Okay. Now, if the kid goes out or something like that, A, your topical didn't work very well, or you stuffed up how you put your needle in and you gave too much local at once, but you had a
Mm.
sharp fingernail. Oh, I'm really sorry. I've got a couple of
Uh,
fingernails. Was it a bit sharp? Was it? Yeah, yeah. Okay. My bad. My bad. I'll make sure my finger's
mm.
in a better spot then. Okay. And you just you put stuff all in, put like 0.05 of a mil, right? Just put a smidge in and just let it work for a minute. Back out again, or you can keep going and you keep going really slow. But keep in mind you've got your fingers and everything in the mouth, right? But it should be less than 1 mil per minute. Like giving local takes a long time. Then you give them a rinse. While they're doing that, usually I'm getting them to wiggle their toes. Can you wiggle your big toe? Wiggle your little toe? Can you wiggle your two big toes? Oh, you might get a bit of funny taste. I think it tastes a bit like cat's wee. You ever tasted cat's wee before? Oh, it's horrible stuff. I used to have a male cat that lived next door. He used to come wee on my door. So you're just talking crap, right? It's the fun thing about kids too. You can just talk crap. Um,
You just make up
Make up
things.
whatever you like, right? And then once that's done, you give them a good rinse, and pretty much for everything, even crowns, pulpotomies, fillings, extractions, definitely, I numb up the palatal as well, right? And I work through just do that chasing technique, and then that way I know I can get rubber dam on. That's not going to hurt, and I know that I got that bloody thing numb. You don't want to get halfway through a pulpotomy and the kid's saying "ow" because it probably is "ow," and then you've got to take the thing off and go numb up again. Okay. Articaine, just use Articaine for pretty much everything. Don't worry about lignocaine for kids. Okay. And you rarely ever need to put a block in. Even for an extraction of a lower E, you shouldn't need to put a block in. Don't block kids. Okay.
Even if you were restoring a 6?
Now, if I'm just doing a restoration of six, I'm generally okay with just an infiltration. If you're going to extract a six, you'll need a block for that. But keep in mind, if you're going to go ahead and extract a few sixes on an 8-year-old or a 9-year-old, they should probably be treated under general anesthetic. That is not a fun experience.
Yeah. No, absolutely. Well, for the most part, blocks are,
I haven't
infills
given a block
are fine.
in probably about 3 years. Erica, I'll give your block. We'll see what happens. I'll probably hit you
That'll
right
be
blank.
that one, right?
We'll see how we go.
I love your point before there about talking with kids and just having fun. And I think it's hard to multitask. I think when you work with kids, there is just your capacity and just your attention, right? Because keeping them distracted and keeping them entertained, whilst particularly being a newer dentist, you're still figuring out the clinical side of things. But over time, also I realized like just taking the pressure away and realizing that like kids aren't judging you for what you are saying, particularly when like the distraction side of things, at least. And I was just thinking before when you're talking about the cat's wee on your doorstep, the amount of times that I make absurd
It's
stories
fun.
for the kids. It's fun.
And like we said before, just simple things. Give every kid a choice, right? So, for example, if you're going to do a prophy, don't just give them the minty prophy. They get two choices. Now, if your practice only has mint flavored prophy, your choices are dog poo or mint. That's it, right?
Yeah.
So, what are they going to
Yeah.
choose? They're going to choose the minty one. Yeah, cool.
I love that. And also your tip about there's always 2 choices,
Only two
nothing more
choices.
than that.
But you've got to give two choices. You do have to give a kid the perception that they're in control. Yeah, give them things that they can control.
Do you have any final pieces of advice for our graduate audience, Tim? You had mentioned that, in a lot of your teachings, you work with like distressed young clinicians and you probably hear a lot of stories and you talk to a lot of different people, whether it be patients or parents or the people that you work with, your referring dentists. I always ask all my guests that has there been a story recently or over the years that's really stuck with you that you think would benefit our grad audience to hear?
Um, not specifically. I will say, Erica, a lot of what I see, a fair portion of it is like failed restorative work, provided where maybe treatment planning wasn't done correctly, and you've now got like a bit of a broken kid and a family that's a couple of grand in the hole, and not all the work, but a portion of the work needs to be redone, or I'm now extracting teeth that had fillings done only 6 months ago. So and a common mistake, and the reason a lot of it occurs, is either no X-rays were taken or an OPG was taken to diagnose decay. Do we diagnose decay on adults with an OPG? No. Where does the vast majority of decay in primary teeth form? Interproximally, right? They've got very shallow general occlusal surfaces, particularly Ds. So you need X-rays. If you can't get X-rays on a kid, you are medico-legally indefensible. I cannot defend you in a court if you were to provide treatment to a kid that went pear-shaped and you didn't have an X-ray. So a lot of
Mhm.
the issues that I see arise from a lack of X-rays. So you've got to get good at taking X-rays.
At what age do you start?
18 months after posterior contacts have been there, so roughly about the age of 4. Yeah. We've actually just done a recent series of posts on our website of when to take X-rays and tips on how to do that as well, right? If you ever come on any of, like we run courses, right? Restorative courses, hygiene courses. We've got videos and things for me to show you how I do them with real life, recordings of us in the clinic with patients, so you can sort of see. They don't always need to be perfect, but you got to get them. Yeah, you got to get them. I find that's the two hardest parts of pediatric dentistry is treatment planning and taking X-rays. The rest of it's pretty simple.
That's the most important, starting off well.
Yeah,
Yeah. Well, thank you, Tim. Thank you for a wonderful chat. I feel like it was so insightful and gained so much from it. So I really appreciate all the knowledge you've shared
my
with us
pleasure.
today.
Thanks for having me, Erica. It's been great.
And thank you guys so much for tuning in to another episode of the Graduate Dentist Podcast. I really hope you've taken something valuable away from this episode and that you feel heard, you feel seen, inspired, and optimistic about our journey as graduate dentists. As I always say, we're in it together, so let's spread the word, let's share the love, send this to your friends, your colleagues, and those who are on a similar path who you feel may benefit from being part of the community. I'd love to hear your thoughts, so send me a message, and we'll see you again in 2 weeks' time for another episode.